Hello folks, in this video we're going to talk about switching anti-VEGF agents in patients with diabetic macular edema. Before we go into the video, let's talk about general and plants culture here. This flower is called Catlleya Intermedia Cerulea variation. It's a local flower orchid of the southern part of Brazil. Enjoy this flower while you hear this conversation about switching anti-VEGF agents. Refractory diabetic macular edema has been reported in up to 40% of the patients undergoing anti-VEGF injections. But what it is refractory DME? Most of the studies consider refractory DME in patients who remain with a central macular thickness over 300 micra, or if there is less than 10% reduction of central macular thickness after 3 to 6 injections. The DRCR retina network considers 250 micra as cut for persistent DME. Options for refractory DME include changing to other types of medications like steroid, trying subthreshold or focal laser, or switching to a different anti-VEGF medication, and this will be the focus of this video. Before we go into the results of switching agents, let's discuss about the rationale. We need to keep in mind that anti-VEGF agents, aflibercept, ranibizumab or bevacizumab, they may have slightly different cytokines target binding. They may have binding affinity of different potencies, and they have different efficacy. On top of that, tachyphylaxis has been reported and documented due to the upregulation of VEGF receptors or increased production of VEGF cytokine itself in the blood and consequently in the eye. Finally, each individual has a different polymorphism or reaction to the drug itself, and this reaction may change from one drug to the other. Let's talk about what data we have so far. If the patient is undergoing injection with bevacizumab, once it's refractory, switching to ranibizumab or aflibercept may result in improvement in vision and reduction in central macular thickness. On the other hand, if the patient is undergoing injection with ranibizumab, switching to aflibercept may induce reduction in central macular thickness. However, most of the studies consider that the function, the visual acuity, does not improve significantly. An important subject concerns finding biomarkers which would identify which patient may benefit of switching to one type of medication or the other. We have a video that discusses which patients with DME may have inflammatory signs, and I'll leave this link in the description of the video. In the literature, some studies discuss that patients who have early visual positive response may be better candidates for switching later once they have refractory status. In conclusion, switching from bevacizumab is usually good when the patient has refractory DME. You can switch to ranibizumab or aflibercept. Once the patient is undergoing ranibizumab or aflibercept, switching is a less efficient idea. The key is to find imaging genetic or blood biomarkers, so we can identify which patient respond to one drug or to the other. And now we have the newer anti-VEGF agents like faricimab coming into the clinical practice. Identification of the genetics and the polymorphisms may allow to better results in the future. I hope you liked this little overview and discussion about switching and when switching anti-VEGF agents. See you on the next video. Thank you.